Okay, thank you. And thank you everyone for joining, and lovely to see so many people. As Kathy has said, this is the first of a number of sessions which we will be running over the next week or two. I particularly want to thank our panel members, Dr. John O'Brien, Dr. Jean Lane, Professor Sean Kennelly, and Dr. Regina McQuillan, who have kindly agreed to support us, and of course Dr. Kathy Payne and the All Ireland Institute. So I'm just going to go through a brief presentation on some of the issues around supporting people with an intellectual disability with COVID-19, and really to give a lot of time for some questions. Okay, so the session is going to cover contextualizing COVID-19 and people with intellectual disability. We're going to touch on advanced care planning because this has come in from a lot of participants today. We are going to have a separate session on that. Issues around the transfer of people with ID to the acute hospital setting, the pros and cons of that, and then palliative care for preparing for people with multiple morbidities. Now we have a lot of people joining today from different countries, and much of what I would be talking about really is based on our own HSE guidelines and Department of Health guidelines, of which of course and WHO guidelines. So people need to understand these in the context of their own countries as well. So just a little bit about the virus. We all probably are aware that most people will experience mild to moderate respiratory illness and will recover without requiring treatment. Other people and people with underlying medical problems like diabetes, cardiovascular disease, respiratory disease and cancer are more likely to develop more serious symptoms. And the most important issue, and we've heard a lot about this, is around protecting. The first thing we have to do is to try and prevent people from getting it. So this is all of our infection control procedures, our hygiene, our hand washing, our physical distancing and cocooning, and all of those are the measures now which are in here in Ireland. And we know that the virus spreads primarily through droplets of saliva or discharge from the nose through coughing or sneezing. In Ireland, we have, just looking at the number and the population that we're talking about, we have a national intellectual disability database, and this is very useful because we know the numbers. We've around over 28,000 people registered on the database in 2017, and you can see from this that we have what we're looking at is increasing demographic trends with increasing trends in aging prevalence rates. And of course we know that our biggest risk is for people who are older and with multiple morbidities. So this is important. And just to say that not everyone, of course, with an intellectual disability is registered on this database. Nonetheless, it does give us a good understanding. So one of the big questions, of course, out there is, are people with ID at greater risk? And what I could say at this stage is we actually don't know. We know that risk is influenced by increasing age, and people age 70 and over, even fit and well, are at increased risk. People who have diabetes, cardiovascular failure, cancer, immunotherapy, severe respiratory conditions, multiple chronic conditions, and multiple morbidity. And there's no evidence that having an intellectual disability per se is a risk factor. But what we do know is that there are higher levels of multiple morbidity in people with an intellectual disability. And we have very good data in Ireland now on this, data emerging from the longitudinal study on ageing in people with intellectual disability, or IDS TILDA. And from that study, we know that the prevalence of multiple morbidity is high, and we're looking at multiple morbidity for many people across the entire adult life course. So we would have shown that about 71% of older people with an intellectual disability in Ireland have 2 or more health conditions, and this is higher than that of the general population. We are looking at about 59% of the population. And we do know that multiple morbidity increases with age, but we also see that even people in the younger age cohorts, 40 to 49 years, 63% had multiple morbidity, 72% in those aged 50 to 65 years, and this increased with age, with 86% in those aged 65 years and older presenting with multiple morbidity. We also know that multiple morbidity is higher among those with more severe levels of intellectual disability, and we also know that there's a high prevalence of neurological conditions in this population. 30%, for example, of people with ID have epilepsy. And we also know that 9.3% of diabetes and about 11% of women. And we know that diabetes in its own right, of course, is a risk factor for poor outcomes if people develop COVID-19. There's also been concern about people with Down syndrome, and we know that people with Down syndrome often have this. Down syndrome itself is associated often with having more chronic conditions. Many will have pre-existing cardiovascular and respiratory problems, and we know that there's a higher rate of dementia in this population. And we know that there's high rates of respiratory disease in people with intellectual disability, regardless of COVID-19, and that respiratory disease is a leading cause of death for this population. So pneumonia, including aspiration pneumonia, is common. Dysphagia, which is problems with swallowing, of course, which puts people at risk of pneumonia, is common. And even people, and these are higher, again, these risk factors in people with severe to profound levels of intellectual disability. And there are other factors which are critical and important in this population. We know that 52% of people with an intellectual disability have an emotional or mental health problem, and 15% suffer from anxiety. And this is so, and there's going to be now heightened anxiety for everybody in our society, as well as people with intellectual disability, because of the pandemic that's currently happening. And of course, for many, the concept of social distancing may be difficult to understand and adhere to. And people may not tolerate the testing or interventions such as social isolation. And I'm going to come back to those later on. And that is important. But even if people doesn't tolerate a test, it's important to remember that testing doesn't equate with no treatment, and it doesn't affect treatment, and that is important. But there is the potential impact in terms of worry and disruption due to COVID is particularly, it's of particular importance for this population, where they may be subjected to emotional and psychological and mental distress during this particular crisis. The focus, of course, has to be on prevention. I'm not going to dwell on this. There is great information on the HSE website. It is all about adhering to the hygiene measures, the social distancing, the isolation, etc. And I think they're all, people need to access those off the website. Some questions have come in is, should people with ID be tested for COVID-19? And the answer, of course, to that is yes. The same guidance for testing should be used for people as for everybody else. And the critical issues are whether symptoms or evidence that a person with ID has COVID-19, and they're the critical issues. So is there any evidence of them presenting with symptoms, or have they been in contact with somebody who has symptoms? And if this is the case, the first step is to notify your GP and to follow the HSE and our Department of Health guidelines in Ireland, and similar guidelines in different countries. And testing and the results though, and getting the results in time, this is a critical issue, because social isolation for people with an intellectual disability can be especially difficult. So we need to try and get the testing and the results. And we know this is challenging, not only for people with ID, but for the population at large. And if you're, in a setting or in a group home, we have to begin to ask how many are displaying symptoms. So if we have 1 to 2 people in that group home who have a definitive diagnosis, we probably are looking at something like a cluster forming. And if anyone else in that group home presents with symptoms of respiratory illness or some of the symptoms, we probably can fairly, with a degree of certainty, say it's likely to be COVID. So if an individual displays symptoms and you need to request a test by the GP, they should be isolated and the symptoms monitored while you're awaiting on the test and the test result. But managing isolation can be challenging. And you have to ask some questions like, is it possible within your current environment? For example, does the person have their own room? And can this space be made more therapeutic? Can we look at the person's interests in things like music, arts, or activities to keep the individual occupied? And is there a place for the person to wander apace while in isolation? So is there a small enclosed garden? Or is there a place within your facility that would be more calming? Because this may be very important for this population. And is there another space maybe within the same service better suited for isolation? So I know many of the services, organisations in Ireland, they're looking to see within their organisation, can they create isolation spaces so that somebody could move to there, which have greater space and allow for safe wandering. Because oftentimes, and particularly when people are very anxious, wandering up for some people may be therapeutic. So we need to look and to see how we can support this. And our attempts at managing isolation putting others at risk. So we need to see, are restrictions justified? And what are the least restrictive measures available to you? And the big issue is, if we have somebody with a definitive diagnosis, we have to look at the issue around the protection of other people who will be sharing that group home or that space with that individual. And we don't want to put other people at risk, and we don't want to put staff at risk, because staff will be required to be around to support this population. So we have to really try to manage what's in the interest of the individual, but also what's in the interest of other people who are living there and the staff. And there may be times, and we're doing, that medication may be required to manage distress. And it should be the last resort, but if somebody is perhaps pacing and they're very distressed and they're not able to sit, we can't really leave somebody in that state of distress. And we're going to be running an additional session looking at managing isolation and practical approaches, and that's going to be run on the 9th of April. And you have to ask yourself, would an individual benefit from being moved to a different facility? We recently had an ethical framework for decision making published by the Department of Health in Ireland, and I think this is very helpful and would encourage people to look at this. And this states that legitimate restrictions to an individual's freedom can be justified in cases where exercising that freedom places others at significant risk. And enacting any measure where personal freedom is limited, the least restrictive effective measure should be adopted. And I think what we're seeing is we're having to do probably approaches and care approaches that we would never have dreamt of before. And this is for everyone at large. We never imagined that we would see wills being signed through looking in through a window, or that we would see people dying with limited family members around them, or that we would see field hospitals opening up in our localities. And this is the reality of how we're operating in a pandemic, and everything changes. And we have to reevaluate what we are doing, and this is very difficult, because this means perhaps we are forced to do things that we would never have dreamt of doing, our approaches to care before. But what we do understand, hopefully people will recover and we can revert back within the shortest period of time to more freedom and different arrangements. Advanced care planning, and this is so important. And why do we think it's important? Well, we're in a crisis, and that's really important, but we want to avoid decision making in crisis situations. We want to try and keep the person's wishes and to know the person's wishes when they're well, if at all possible. But really importantly, we want to make a pathway of care clear, and that everyone who is supporting that individual, including the individual themselves, if possible, understands the pros and cons of, for example, transferring to acute hospital. So we need everyone to be clear about what the pathway of care is for an individual person, and this can guide the healthcare team and make decisions on the patient's behalf. The big issue is when. All I can say is we need to prepare. You need to know your population. You need to know who are the most at risk. And we need to develop advanced care plans now. So the people who are most at risk are those who are age 70 and over, and those who have multiple morbidity. And we need to provide a sensible approach and look at those people who are most at risk initially. But we don't want to overwhelm the system and have people very anxious by coming in perhaps to group homes everywhere and instituting care plans for perhaps people who at this time are not seen as a high risk. They're younger, they don't have health conditions, etc. So I think be sensible about the approach. Care planning now, we need to use simple language and easy read materials, and we have some of those developed, and they can be downloaded from the TCID website. And we need to have it well documented, who was involved, what was discussed, the decisions signed and dated. And we can come back to these again, of course, and these need and should be revisited. And there's accessible materials, but what I really want to say is time is not on our side. So we need to get advanced care plans for those who are most at risk in place now. And we will be running a separate session again on advanced care planning and anticipatory prescribing in a crisis. And this will be run next Tuesday from 11 to 12. In relation to transmission to hospital, well, we know that the hospital situation is challenging at the best of times, but is particularly challenging at this moment in time. And we need to have really thought through what is the best care pathway for an individual. And we have to remember that most people will have mild symptoms and will recover from COVID. A small percentage of people will unfortunately die, and this may include people with an intellectual disability. But when people with an intellectual disability have multiple health concerns, particularly pre-existing heart disease, diabetes, respiratory problems, they're likely to have poorer outcomes from transfer to an acute hospital. And they're more likely to benefit from and have better outcomes if they're cared for in a familiar environment with familiar staff, and we need to support those staff and upskill those staff to be able to give care. So admission to the acute hospital is not the first line of defence. I think it really is the last line of defence. And what we need to understand as well, that there is no specific treatment for COVID-19. This is a virus, there's no antibiotic treatment. So we have to see, does the individual require aggressive supportive care, ventilation, intubation? This may be burdensome for some people, but the most important thing is what's their chance of surviving this? And we can see, and we will have a chance to talk in the discussion period, looking at survival rates, even for the fit and well post-intubation. And staff and family members will not be able to accompany the person to hospital. And we have to ask ourselves, how will the person cope with this? Because very often within the intellectual disability arena, we accompany people to hospital and we understand that they require that. So we have to ask, will the last days in hospital isolation provide added stress to the individual, to the staff, to family and peers? And we need to understand that if somebody isn't going to benefit from the treatments, that care can be properly cared for outside an acute setting, and we need to see how we can manage that. But others who will become acutely unwell and prior to COVID-19 were deemed fit and well, will well benefit from transfer to the acute hospital system, and this care pathway must be considered and each individual must be assessed on a case-by-case basis. So regardless of having an ID or not, people must be assessed as to whether critical care is needed, and the person will be able to cope and is likely to have a good outcome from this. So the care pathway should be based on multiple morbidity and the benefits and burdens, and understood in the context of pre-existing intellectual impairment. So we are really advocating for a multi-principle approach, including the patient's pre-morbid health status, the will and preference if known, the presence of comorbidity, the overall health and general frailty. And I know that there has been some concern in the field in relation to the use of something like the Clinical Frailty Index. It's a blunt instrument when applied to people with intellectual disability, and it hasn't really been validated for this population. So what we're saying is you really need a multi-principle approach taking in all of these issues. And the main reasons why people might be transferred to hospital is that they would benefit from hospital care. And as I mentioned, prior to this were deemed fit and well with no major health comorbidities. But what we do need to know is that the window of care is short. Decline happens very quickly. So if people are going to benefit, we need to transfer them early and briskly to the hospital. And the second reason why people with an intellectual disability might end up being transferred is that they cannot be cared for where they are. There's not the staffing, there's not the skills or the appropriate care, and our environment. And we need to be honest, and what I'm saying to people, be honest and realistic about what you can and you can't do. We need to provide care locally, and we need staff to be able to recognise the symptoms. And this is up on the HSE website, and I'm not going to go through this list, but you're looking at altered physical and respiratory symptoms, worsening of cough, shortness of breath, increasing temperature, and also alert for other new symptoms like maybe clouding of urine, diarrhea, some GIT symptoms, and then altered mental status, worsening of agitation, confusion, delirium. And this is all available on the HSE website, and please look at those documents. And providing care locally, if we're going to provide it, of course we need to isolate the person. We need to use PPE as recommended. We need to assign staff to an isolation area and the person needs to be isolated. We need to monitor vital signs and use escalation protocol and clinical judgment. And this is really important. Monitor intake and outcome, and you're evaluating symptoms as to the appropriate, as appropriate for improvement or deterioration. So you're really keeping an eye on what's happening with that person. And then you're constantly referring to the advanced care plan and to anticipatory guidance. And ensure that you have supportive care for things like hypoxia, for pain, for fever, and for other symptoms. And stay in regular contact with the person's family and the advocate and carers, and this is important. And one, I think, important assistance may be the use of telemedicine, and is this an option within our service? And establishing a relationship with our local hospital. And what's really important is not to wait until we have a case. I think it's important that we establish those relationships early. And this is here from the HSE website, the assessment and testing pathway. And people can download that and see that themselves. And again, when we're providing care, using the like of the Pinch Me tool, and that again is up on this website, looking at things like pain, infection, nutrition, constipation, communication, hydration, medication, and the environment. Oral care, skin care, all of these are all important with respect to comfort care. So you need to plan and be proactive. Engage with GPs, and many GPs, it'll probably be by telephone consultation. But in group homes and in non-nursing settings, how are you going to manage this? You have the nursing support to provide care. And I think one of the advantages in Ireland is we do have intellectual disability nurses available to support this. And this is a huge advantage and hopefully will be beneficial now in this particular crisis. And you will require nursing supports, particularly for symptom management around subcuts and syringe drivers. And you need to get linked to the acute hospital and palliative care. So when it comes to advanced care planning and anticipatory prescribing, there's going to be a separate webinar on this next week on Tuesday. And I'm just going to quickly look at some of the HSE guidance, and please look at the one-pager on the HSE website in relation to this. But in the last days of life, some of the key symptoms and medications. People who have got COVID are going to suffer from breathlessness. Dyspnea is going to be common. They're likely to have a dry cough. So the people, you will see this, and this is very distressing because the people will be gasping for air. There is a kind of an air hunger, and the more breathlessness you become, the more anxious people become. So generally you're looking at the line of treatment is opioid medications, you're looking at your morphine sulfate, and you may need to take the edge off the anxiety, and some mild sedation or midazolam is generally the first line of treatment. Again, anxiety is common. It's common in this population even without COVID-19. It's common now in the current climate. But if people are breathless and they are going to be increasingly anxious, and also they have an infection and they're likely to have delirium, and again, you need to look at the line of medications for this. Again, mild sedation with the like of midazolam. If that's not available, levofurosemide or haloperidol may be also used. Pain, it's important to think of pain. People will have perhaps health conditions like arthritis ever before they develop this infection, and they will also have additional pain as a result of the infection in terms of pneumonia, perhaps endocarditis, etc. So again, looking at the opioid medications and morphine sulfate may be generally the first choice of medication. And again, there will be a whole session run on this next week. Anti-secretory medications, again, people near the end of their life, it's very often that secretions will build up. People are not able to cough up these secretions. So you're really and the most important thing is the medications are useful at preventing the buildup of secretions, but not necessarily that terribly helpful in getting rid of secretions that are already built up. So you're looking at the like of Buscopan, or if you don't have that, glycobarporine can be a second line of choice. In some cases, you may have nausea and vomiting, and again, you may use your levofloxacin, or you can use your haloperidol in those cases. So they are some of the medications and some of the symptoms that will need to be managed. And again, as I said, we will have a separate webinar next week to deal with these. But in ID settings, you're going to need a standard operation procedure needs to be developed. There's all the issues around safe custody requirements, around storage, around registry books. Have you got the facilities to do those? And you're going to need to liaise with providers, etc. So I think this is a very difficult time for everyone involved, and we need to be honest and open in our communications about what we can deliver and what you can't deliver. People really should do their own risk assessment and liaise with HICPA in relation to this, and remember that this is a public health issue and there is assistance out there, and we can get assistance, and that's important. But this is a difficult time because there's very long, often very long-standing relationships between the person and staff and family and peers, and there may be multiple bereavements of residents, and grief among staff and peers and families is not to be underestimated. And we will be looking at, again, having a separate session around addressing grief and bereavement. And just to some of the main take-home messages that I want to leave with you is that we need to be diligent. We need to adhere to the HSE and the Department of Health guidelines. And remember that most people will get a mild illness and recover. And I feel that people with intellectual disability are quite a resilient population, and we should hopefully expect them to recover as well. We need advanced care planning is more important than ever. So plan, plan, plan. And know your population and understand the best ways to prepare. So you need to prepare. Hospitalization, we need to understand the benefits and the burdens and have an honest reflection on that. Really look at this using a multi-pronged approach, and particularly looking at age and level of multiple morbidities. And you need to look at developing an isolation zone within your service or within your organization, and be confident that people can be provided with good care in their own home or setting once we have the right supports. But if people are deemed fit and well, of course, they should move, and we feel that the chances of recovery are good. Of course, the care pathway should include hospitalisation. But be realistic and honest with yourself about the level of care you can and cannot support, and we really do need a risk assessment done in your areas around this. These are the upcoming webinars that we will have. So one on advanced care planning and anticipated prescribing during a crisis next Tuesday, the 7th of April. We have one next Thursday on managing isolation and practical approaches. Another one on caring for people who are dying, addressing grief and bereavement. And we will be looking at the series of questions that have come in from participants and developing webinars very quickly to respond to some of those issues. A number of services have requested to see could they get a certificate of completion of this, and if you do want this, yes, that is possible. And if you would like this, to please email Gavin Dan and put in your name and your title and your organisation, and we can get that to you. Just do stay connected. This is our own website here. There is the weekly webinar series, and there is fantastic resources now which have been developed right across the world, and we're trying to put all of these together, both in Ireland and the UK and internationally. And we have all of those uploaded on our website, and you can also access them from the All Ireland Institute of Hospice and Palliative Care. Thank you.